Welcome to everybody who's listening. My name's Yannick, and this is going to be the first lecture of two. I'm from the Patient Safety and Quality Improvement Committee of AFAMEE, which has been newly introduced, as well as from the long-standing PSQI Special Interest Group, which I co-founded. In this lecture, we'll explore how competency-based medical education and entrustable professional activities have evolved and how safety frameworks fit in. In the interest of time and keeping the overall pre-learning for the live webinar straightforward, we'll briefly look at exemplars and discuss how to craft EPAs linked to patient safety outcomes. Here's a roadmap. We'll start with CBME's roots, contrast it with traditional medical training, and define EPAs. Then I'll give two EPA examples, which are 1. Interpreting a chest X-ray, and 2. Safe patient handovers. Next, we'll very briefly touch on Safety 1 and Safety 2 in clinical education. And finally, we'll see how to write EPAs and map them. Medical education was historically structured by time and content. Think Flexner's 910 model. Over the decades, there's been a shift toward outcomes. What abilities do graduates need? CBME emerged from this outcomes movement. In 2010, Frank et al. Described CBME as focusing on accountability and clearly defined outcomes, de-emphasizing time-based training. In CBME, we ask, what tasks should a graduate perform? Then build curricula and assessment around those outcomes. Compared to traditional curricula enveloping fixed rotations and time requirements, CBME is learner-centered. It asks, has this learner demonstrated the needed competencies, rather than simply, has the time passed? CBME reorganizes training around milestones and abilities. It also focuses on frequent assessment for development and potentially lets learners advance at their own pace. In short, CBME defines what to learn, which are competencies, then plans learning activities and assessments to achieve those outcomes. Entrustable professional activities are central to CBME. As Frank and colleagues note, EPAs are essentially competencies in context, or even better, as the 10 Kate, units of daily practice. In other words, an EPA is a professional task which requires multiple competencies to perform, and once a trainee has the needed competencies, we can entrust them to do that task unsupervised. EPAs thus bridge the gap between abstract competencies and real clinical work. Here's an illustrative EPA. Interpreting standard chest radiographs. A learner entrusted with this EPA would be expected to review a chest X-ray, recognize common pathologies like pneumonia, pneumothorax, lines, tubes, etc., and communicate findings to the team. This EPA integrates competencies like clinical reasoning, which is medical knowledge, patient-centered care, and interprofessional communication. We would define its scope, for instance, adult inpatients in the ICU, and note limitations as to complex cases still need supervision. For entrustment, we'd assess if the learner reliably recognizes normal versus abnormal anatomy and can explain it in context. By documenting them learners consistently achieving milestones, we grant higher autonomy. Another example, patient handover to another provider. This EPA was explicitly discussed by 10 Kate and Young in 2012. They describe handover as an EPA requiring integration of clinical, communication, and systems knowledge. It's also time-limited and context-specific. For example, during an end-of-shift sign-out, the trainee must convey the patient's current status and plan, anticipate problems, and ensure shared understanding. Because mistakes in handover can harm patients, we emphasize structured formats like SBAR and teach clear communication. A learner entrusted with this EPA can independently lead a handover with minimal prompting. In training, we would observe handovers and give feedback on completeness and accuracy, aiming to build shared mental models and safety. Let's bring in patient safety. Safety 1 focuses on preventing things that go wrong, investigating errors after they happen. Safety 2, by contrast, is about understanding why everyday care usually succeeds and learning from that. So I will mostly direct you to the latter during this lecture. Deutsch et al. Explained that Safety 2 asks what contributes to successful outcomes, rather than only asking what failed. They note that healthcare is a complex, adaptive system, and human adaptability is a source of safety. So Safety 1 and Safety 2 are complementary. We still learn from errors, but we also study and reinforce good practice. How does this relate to CBME and EPAs? When designing curricula, we can map EPAs to safety outcomes. For example, the handover EPA is directly aligned with reducing communication errors. More broadly, educational activities enhancing flexibility and reflection build resilience, which is a Safety 2 trait. Simulation training exemplifies this. In a simulation with structured debrief, learners rehearse managing novel scenarios. Debriefing models like the Pearl's Guide reflect on what went well and why, reinforcing adaptive expertise. Please be hereby advised to watch the Debriefing the Debriefer webinar on this channel. You'll find a link in the show notes on YouTube. We did together in last March. Well, Deutsch notes that characteristics of an effective simulation align well with resilience, particularly debriefing practices. Thus, simulation and EPA-based training support a Safety 2 mindset, complementing Safety 1 checks like checklists and protocols in clinical training. Finally, how do we write an EPA? Tenkate and Taylor outline 8 components of a full EPA description. Next to title and scope, we also specify potential risks if done poorly, to highlight patient safety stakes and competency domains involved. We list required knowledge, skills, and experiences, which is what training is needed for. We define expected supervision levels at different training stages and how long proficiency is maintained. Each EPA can also be linked to measurable outcomes. For instance, an EPA on chest X-ray interpretation could tie to accuracy metrics or patient outcomes like reduced missed diagnoses. The key is to ensure entrustment decisions ultimately promote patient safety. You don't entrust a learner until they demonstrate the ability to perform safely. Supervisors make these judgments holistically, often asking themselves, would I trust my family member with this trainee? Integrating factors like reliability, integrity, capability, and humility in their assessment. To summarize Lecture 1, CBME refocuses medical education on observable outcomes and competencies. EPAs are practical tasks which embody these competencies in context. Exemplary EPAs, like interpreting chest X-rays or conducting handovers, illustrate how clinical tasks are framed. Patient safety is integral. We apply both Safety 1, that's error prevention, and Safety 2 in training. Finally, writing an EPA means detailing scope, risks, competencies, and entrustment levels. These EPAs then map to safety goals. We only entrust learners once they are shown to be safe and competent. Thank you very much for listening to this lecture, and hopefully see you in the next one.